Okay, everyone, the time is 4 o'clock, and the Nordic time is always on time. So, dear all, good afternoon, a warm welcome to the session Nordic Healthcare in a Global Context. Leadership, Healthcare, and Collective Responsibility. To make it clear, the Nordic countries is not just one country. It's 5 countries. It's Norway, Sweden, Denmark, Finland, and Iceland. So, it's a great pleasure for me to hold a dedicated Nordic session at this Congress, which brings together healthcare leaders, professionals, and collaborators to focus on the service we are all committed to. The Nordic health service model is built on a universal access, strong public trust, and a commitment to equality. Health services are tax-funded and designed to provide high-quality care for all. Collaboration between professionals, management, and employee representatives is a key strength, fostering innovation and resilience. So, at the political level, broad consensus supports healthcare as a shared society responsibility. Across borders, Nordic cooperation, for example, through the Nordic University Hospital Alliance, NUHA, demonstrates how shared learning drives continuous improvement. Within organizations, Nordic leadership emphasizes dialogue, transparency, and trust, enabling leaders and staff to co-create solutions and adapt to change. Globally, the Nordic model shows that equity and efficiency can go hand in hand. Other regions can learn from its trust-based governance and collaborative culture. With these strengths comes responsibility. The Nordic countries have a duty to share their experience, not as a blueprint, of course, but as inspiration for fair, sustainable, and people-centered health systems worldwide. So through this session, we aim to share insights into the Nordic model, highlighting key political perspectives, shaping its development, and how the Nordic countries work together to create sustainable healthcare solutions. This session has been developed in close collaboration with the participants themselves. And we have 6 of them. It's Alma Møller, the Minister of Health from Iceland. It's Rasmus Møgvang, CEO at the Rikshospitalet in Denmark. Bo Hallberg, CEO at Sahlgrenska University Hospital in Sweden. Runolfur Paulsson, CEO, Landspital University Hospital from Iceland. Elina Repponen, Head Physician Customer Relations from HUS University Hospital of Finland. And Catherine Bjerke, Head of International Relations from Oslo University Hospital. And then I have to say, my name is Anders Moen Frafjord, and I am the Deputy CEO at Oslo University Hospital, and also part of the IHF community. After we have 3 presentations, we will go to a panel discussion. And in the panel discussions, we will explore what it means for healthcare leaders to take broader societal responsibility beyond their own organizations, and then discuss how to turn vision into tangible results and real change. It's a pleasure for me to welcome the first speaker. Alma Møller, Minister of Health in Iceland. She is a physician with extensive experience in Iceland's healthcare system and national health authorities. In her presentation, she will outline the Nordic model's core values and its potential to drive further transformation. Welcome.
Good afternoon, ladies and gentlemen. It's an honor to take part in this conference, not only for me as a Minister of Health, but also as a doctor, because I have 30 years of experience as a physician and manager, both in Sweden and Iceland, mostly in intensive care. And there I learned that intensive care units do too much, too late, to too few. and also that an ounce of prevention is better than pound of cure. So I went on to study and work for public health, and there again I realized that equality and politics are crucial to public health. So I ran for the Icelandic Parliament last year and ended up as Minister of Health. The Nordic model is, we can say it is an socio-economic framework combining free market capitalism with a comprehensive welfare state and strong labor rights. Its core principles are freedom, equality, solidarity, human rights, and trust. And the ingredients of trust include transparent communication, accountability, collaborative policymaking, civic engagement, and low corruption. And the Nordic model is also a social contract, universal access to education, social services, and healthcare, social safety nets for all. And there you see the Nordic countries, Finland, Sweden, Norway with Svalbard, Denmark with Faroe Islands and Greenland, and my country, Iceland. And in healthcare, we look at health care and public health as a social right and collective responsibility. And as already mentioned, it is a single-payer system, tax-funded, with minimal user fees. And people enjoy comprehensive coverage from prevention and primary care to hospital care and rehabilitation, all supported by solid legal frameworks on services, patient rights, and data protection. I guess we all face similar challenges. Growing demand for healthcare due to aging population, more chronic disease, and new, often expensive treatments. There is constant competition for public funding, most recently from security and defense needs. We lack enough staff, and the reality is complex. Some services lack an evidence-based foundation. It is difficult to ensure quality, safety, and continuity of care, and expectations from the public, social media, and traditional media can be unrealistic. On top of that, new public health challenges have emerged: screen use and social media, the marketing of unhealthy food, new nicotine products, and alcohol, as well as social isolation, loneliness, and violence. And I haven't really mentioned the big one yet, like climate change and antimicrobial resistance. And clearly the system is unsustainable if left unchanged. But how do we face these challenges? We must face them head on, just as we Icelanders run toward a volcanic eruption, not away from it, like most people do. And I find it useful to focus on value of healthcare services. We must get as much health as possible for the money we spend. And since our funding comes from taxpayers, we can either raise taxes, which never makes politicians popular, or we can improve productivity. And we must use our money and resources wisely through coordination and cooperation between levels of care, between institutions, between the public and private sectors, and between countries, just as we are discussing here today. And we must also do the right things, provide the right treatment in the right way at the right time, focus on quality and safety, and eliminating waste. I am personally very interested in reducing what we call low-value care. As a former chief of ICU, I found it useful to ask myself these two questions regularly. Are we doing something we shouldn't be doing, or are we not doing something we should be doing? And lastly, we must also make good use of innovation and technology, especially those that save staff time. It is equally vital to strengthen public health, to reduce or delay the need for health services in the first place. I have been pleasantly surprised that public health has been on top of the agenda at meetings of the European health ministers, and it makes, of course, perfect sense as it saves resources and money in the long run. And these are our focus points in Iceland at the moment. We are aiming at stronger primary health care. We are, of course, going for innovation and digital health integration. We are looking more and more between health and social sectors integration. We aim at improving public health. We are taking our first steps when it comes to personalized prevention and precision medicine, which obviously we can be good at since we are the most genomic sequenced population on Earth. We are, as I guess all of you, working with emergency preparedness and response and increased international collaboration. When it comes to developing hospital operations, the CEO of our only university hospital, he is here and he will take part in the panel. He is working to ensure quality and safety despite limited human resources and use data for policy-making, goal-setting, and daily management, as is standardization of processes and procedures. And an aim is to use human resources wisely through teamwork and redistribution of tasks between healthcare profession whenever possible. Productivity, as I mentioned, is important, but it must never come at the expense of quality. There is strong focus on health technology solutions that improve services and ease the workload of staff. And we must nurture the academic role of the university hospital, both to discover new knowledge and solutions and to retain staff. Iceland is currently spending 8.3% of GDP on healthcare, the lowest among the Nordics. We surely are facing challenges such as long waiting times for some treatment, and we need to strengthen our mental health services. But overall, our results are good, for example, in preventable mortality, where we have performed well for a long time, both in treatable and preventable mortality. Finally, we must never forget that healthcare is all about people, not system. And here you see a picture of my mother at her 95th birthday. And by coincidence, we were dressed almost the same, and people still tease me for dressing like a 95-year-old. And she lived a healthy, active life, and it paid off. She hardly needed any health care and reached the age of 101 in good health and still in her own home until the very end. So she makes the case for me when I talk about health promotion and public health. And to conclude, health is what matters most. 80% of Icelanders consider it the most important factor when it comes to own quality of life. In my opinion, we must pay greater attention to public health, both in terms of health promotion and prevention, primary, secondary, and tertiary. Healthy children learn better and healthy adults perform better. And in the long run, this will all allow us to afford more specialist care. And I'm saying this since here are mostly CEOs of hospitals. A well-being economy puts people and planet before profit, measuring success not just by GDP, but by human and ecological well-being. And Finland and Iceland are among the countries that lead the way when it comes to well-being economy. And I think that this truly captures the essence of the Nordic model. And finally, we must stop seeing healthcare as an economic burden. Health is the foundation of development and our future. Thank you.
Thank you very much, Alma, for your valuable insights. Now I'm going to welcome up on stage Rasmus Møgelvang. He is the CEO at Rikshospitalet in Copenhagen, Denmark, and also chair of NOHA. His talk will highlight how cross-border collaboration in the Nordic region supports better and more sustainable healthcare. Welcome.
Thank you very much, Anders. Thank you very much for the opportunity to have a talk about the Nordic healthcare system, and also thank you very much for so many people attending at this late hours. My name is Rasmus Møgelvang, and I am CEO of the National Hospital in Copenhagen, Denmark. But today I'm here representing the Nordic University Hospital Alliance, which is an alliance of all the university hospitals in the Nordic countries, but represented by the university hospitals in the capitals of the 5 Nordic countries. But more about NOHA later. First of all, I would come with this perspective, which I firmly believe that all of us who are in healthcare, we need to be able to do better with less. And it is interesting that not only in the Nordic countries, but all over the world, we see that our healthcare system face many shared challenges. But the way we look at them and the way we try to solve them is normally, solely, to hire more staff and to put in more resources into the healthcare system. And that is simply not sustainable. It is not sustainable when you look at the double demographic pressure, which means that we have an increasing and more patients and less staff. But also when we look at climate, it is actually a disaster when we look at the healthcare system. And you heard some of you yesterday that if global healthcare was considered to be a country, we would be number 5 in the world doing emission in the sense of climate. And when you look at that, the climate change is the single worst factor affecting global health. It is actually our responsibility to look into what is more sustainable. And that is not to add more, that is not to hire more staff, that is not to put more resources in, but is actually to reduce waste and use our resources better. And we, in the Nordic countries, believe that we are actually able to do that. We actually believe that we have a huge potential, if we do it wisely, that we could actually put it in from low-value care, as the health minister said, into high-value care. But it's not easy. And it's all come back to leadership. So I also firmly believe that this is really a huge problem, a huge task, and we cannot use yesterday's methods to solve tomorrow's problems. So we actually need to accelerate, and we need to do a paradigm shift. We need to do something completely different. And first of all, we need to recognize that problem. We need to recognize that it's a crisis, like we did, many of us, during COVID-19, and like we have done during other things in world history. And we are at that stage now that we need to do something radically different. First of all, we need to be humble, show some humility. know that we are not the best at everything we do. And you might laugh at this, but I come from a big university hospital. And to be honest, we are thriving being in the belief that we are the best at everything. And I'm sad to say it's rarely the case, but it's a good ambition. But it is rarely a rare case that we are. And we need to be much more interested in learning from others. So what we try now is to strive to be number one at being number two. Identifying who can we learn from and actually learn and do. So that is one thing, to be humble. When you have gone to that phase, then you need to be curious. Then you actually have to lean into other organizations, learn from them, and this is a perfect setting for that. To expand your network and talk to each other and actually be curious about what do your fellow colleagues from other hospitals around the world do differently. Where can you learn from them? And when you have learned that, then you need to be ready to change. Be ready to do that pivot in your direction, to do something differently. And to believe that in large organizations that the university hospitals represent, that it can all be top down, that is not very agile. And that is not a fast way to do transformation. So we need to empower our staff. We need to loosen our reins. We need to believe and trust in our employees and colleagues that they are the one who knows best. They are close to the task. We need to empower them to take the decision. Otherwise, we cannot accelerate at the speed that is needed. And that is what we try in NUHA. And when we try that, then we also realize that we need collaboration. And the thing is, when we do this, people also want to collaborate with us. So that is actually the backbone of the NUHA, the Nordic University Hospital Alliance. That is in that spirit it is made. That is what we believe in. And that means that we are actually very transparent in what we are doing. It is not just the CEOs meeting regularly. It's actually our organization meeting, being transparent about what do we do, benchmarking, learn from each other, make people visit each other's organization on all levels. Also be transparent about who is actually have the expertise in this area. Realizing that we are all just small countries with similar changes, but together we stand stronger. Realizing that we cannot be the best in the world at everything. In some areas, it might be better for Danish patients to go to Stockholm, or Oslo, or Reykjavik, or Helsinki, and vice versa. And we already have a lot of experiences now that our patients is actually doing that. And we need to accelerate on that part as well. But that is the essence of NUHA, to learn from each other and to realize that we are all too small, we need to collaborate, and we cannot be world's best at everything. But together, we stand stronger. And to give you an example, I will talk about a mutual collaboration, because we do a lot of joint research and clinical trials, but this is even more into our organizations. And the platform trials is the realization that we do not have evidence for all what we do. And I know this is not a surprise for you, but what became a surprise for me was the amount of lack of evidence. I used to work as a professor in cardiology, and when people ask me, how much evidence do you got? I would fairly say 70% or something like that. But on average, we only have 10% evidence of what we're doing. In cardiology, we have 14%, but it's not a lot. So there's a huge potential identifying the things we do if we're actually doing what is good for the patient. Is it worth all the resources? So we need to figure out what is good for the patient and what is not. And that is a huge thing. So the platform trials is a way to deal with that. So what we've done is that we have organized around a specialty. The first case is actually intensive care medicine, because intensive care medicine started in the 50s. It started with a manual ventilator and a bed and a patient. And now when you come into an intensive care unit, it looked like a space station, because we just put a lot of stuff in there and hardly without any evidence. So we started there because we think the potential is big. And we have made a platform where we have done all the legislation. We have hired the statisticians. We have done the protocols. And we made it easy to work with a lot of series of testing of daily clinical practice. And then we have built the software. So it's easy for the clinician, even the ones who don't know that we are actually doing studies, but just doing their regular daily clinical routine. When they order something, the machine says, you should order this instead, because this is what we're doing right now. And that is the way we're doing it. So right now we're testing antidiuretics, antibiotics, and IV fluids. And also some of the nursing regimes, because we have done a lot of nursing regimes in the intensive care unit without any evidence. And the idea is that we scale up evidence to find out if we actually have enough evidence for what we're doing, identifying what is of low value or what may even be harmful, and stop doing that, and then use the resources on what is of high value. And the thing why we started out with doing this is because we showed that a certain brand of IV fluids that we used in intensive care units actually increased the mortality for our patient. And that was the reason why it was stopped afterwards worldwide. We don't know, when we don't have evidence, we don't know the value of it to the patient, and we don't know if we harm our patients. So this is a machine, you can say, that makes it easy to test daily clinical life. So it's easy to add on, but it needs volume. And that is why we do it in the Nordic countries, because then we have 5 countries, all the intensive care units in all the university hospitals. And then we get evidence quick. Then it means that we on a monthly basis know that it should be this antidiuretic or this or none of them. And that is the idea about the platform trials. And it's not exclusive. So we try to make a machine, and every hospital that wants to join will try to fit them into this, because we need each other, because we need volumes to know what is best for our patients. And that is the idea about platform trials. So I said we started in Copenhagen on behalf of all the Nordic countries in intensive care medicine. Now Oslo University Hospital is looking into geronto-oncology to do that on behalf of all the Nordic countries. Helsinki looks into the pediatric area, and so forth. And we hope that every university hospital in the Nordic countries will take lead on a certain area to speed up knowledge, so we can move our resources from what is of low value to high value for our patients. So that is basically what NUHA is about. Collaboration between countries, knowing that together we are not as good as we believe we are, but together we will be much better. It's just an example, concrete on that, and that was from me. Thank you very much.
Thanks a lot, Rasmus. And the third speaker, it's a pleasure to welcome Bobo Hallberg. He's the CEO of Sahlgrenska University Hospital in Gothenburg in Sweden. He's a physician with extensive leadership and international experience. He will share examples of bilateral collaboration and innovative care models that improve healthcare services.
Thank you, Anders, and thank you to the organization committee and to Ron. And also, I'm honored to be standing here in front of the minister, and also glad that you came this afternoon. So what I would try to do is to talk about how do we drive transformation, and dive a little bit deeper into what Rasmus was talking about, the Nordic collaborations in between the university hospital, and going into how we have strengthen our partnership with our friends in Oslo, which is close to Gothenburg, where my hospital is based on the west Swedish coast. I'm also the chairman of the Swedish University Hospital Alliances, representing the 7 university hospitals. The case today would be about how we are trying to work with the hospital at home framework and trying to understand how we can move that into our ways of working in the comprehensive healthcare system. Just a quick run through what is Sahlgrenska University Hospital. It's a large university hospital. We see around 400,000 patients per year. We do 1.4 million visits, 66,000 procedures, and we are 17,400 staff, which is almost the size of Oslo. They are a little bit bigger, so we are a good match. We have a turnaround of 2.1 billion euros for our operations. And we have put up an ambitious goal. We want to be one of the leading university hospitals in Europe by 2032. And there are a couple of things in this slide which is extra important. We do focus on our people, of course. That is the most important asset we have. We focus on our patients. What is good for them is good for us. And we're focusing on our processes. The lighthouse here is a framework from Chalmers Technical University School. It's a sustainability lighthouse. So it's guide a sustainable transformation. Keywords, this is something we do together for sustainable future, both in sociology and ecology sustainable. We are transforming, and we do that, of course, on focus on quality, accessibility, patient safety, research, training, innovation in the comprehensive care system. So we're not just focusing on our own services, we're engaging with the municipality care, with the primary care, in the comprehensive care system. We call our transformation program 6.0 because we are building on our history. This is the 6th version of our hospital, but we are also in the 5th industrial transformation period at this moment. So for us, this is trying to look around next corner, what is the mode of delivery in the future. To try to tease that out, we have formed 7 strategic partnerships. One of them is in Oslo, where we're focusing on change management. How to drive change. If it works in our setting, can it actually also work in the Norwegian setting? Could it be transferred into Copenhagen or to Iceland? And trying to test these things out. And especially in this collaboration, you can see that we have a couple of different areas, but in this one we are focusing on the new care models. In Oslo it's called OSU Hemma, and in Swedish it's Sahlgrenska Hemma. It's our hospital at home programs. We put the leadership teams from the both projects together, and we are asking them how your strategy could be put together. The Sahlgrenska Home is a comprehensive strategy to move care from the hospital into home. And it's also on trying out these new ways of working, both in technical and digital solution. We are funded by the Swedish Innovation System, and we are building on the care models we have. So try to do that. We have a couple of strengths. We have a strong pre-hospital ambulatory care setting. We have a strong leadership on all levels. We do have a strong transformation program. We have in place collaboration with municipality and primary care, and we work on a regional, national level. So this is our hospital at home program. It comprises of a rapid response teams, pre-hospital emergency care, palliative teams, psychiatry, a couple of others, like maternity at home or neonatal care at home, and then of course moving things to the patient's self-care. So the model is built on the whole hospital system, and we are focusing on admission avoidance, early discharge, and self-outpatient clinics, because we need to move out of the hospital. So the collaboration objectives is to learn from each other, find out the similarities and differences. We are finding joint forces where we drive implementation and development. We put up a combined research and education program. We are working to find out policies and definitions and also regulatory issues we need to address policymaker and the governmental level when we're trying to change care. Of course, health economics, cost-benefit evaluations, and finding these new digital and technical implementation tools, working close with industry in a partnership. So the two program, where are we strong and where are we weaker? How can we help each other? So in OSET, in Oslo Home, they are teaching us on how to implement digital pathways and remote care because they are more mature. We are learning, and as Rasmus said, listening is important. Rapid response teams and admission avoidance, that is our strength. And we're now putting the teams together, exchanging the ideas, and letting the people closest to the patients try the new ways of working. So establishing contact on the operational level so they can implement, giving them space enough to test, and also secure that we are in line with the line organization at each hospital, coming together, working in innovative structure, and just to give you an example of the cases. So here you have the numbers of admissions during the last 5 years. And by changing the ways of working, we were able to reduce the number of admissions with an outpatient program. We have 52 mobile teams moving around in our area, and we're actually, year by year, you can see that we're cutting down the admissions of the elderly, the people that is treated better at home. So by having a rapid response team in place, getting out to the patient and working with diagnostic tools, and we can see that we are lowering the admissions of the elderly into our healthcare system. So we think that working together, we will develop the future of healthcare. We believe that this Nordic collaboration setting is one way of finding new ways of working, going to faster implementation. Our model is listen and learn, be brave and implement, and stay close to your people. Thank you for listening.
Thanks a lot, Bobo. Very interesting. Now I will welcome the panelists, Bobo, Alma, Rasmus, Hrolfur, Elina, and Catherine. Warm applause. Enough chairs. Okay. You now gained insight into the Nordic health model, its political context, and a leadership model based on trust and shared responsibility. We will now move into the panel discussion, diving deeper into the key messages from our speakers. We'll try to discuss how senior leaders can set direction to meet political and societal needs and move from words and vision to concrete action. Så vi runder for Palsson, CEO at Landspitali University Hospital of Iceland. You have just heard your Minister of Health, your chief. How do you respond as a CEO to political priorities in Iceland? She has also talked about productivity.
You like me to enter a political debate here?
No,
No, I don't think
of course.
so. I don't think so. Well, first of all, the minister of health outlined pretty well the Nordic model of healthcare and the challenges that we are facing in Iceland, basically the same as everyone else, and some measures that are being taken to address those. From my perspective as CEO of the University Hospital, I mean, we are facing mounting challenges. There are certain features in the Icelandic healthcare system and the Icelandic society that differ from our neighboring countries, although pretty much we are the same, you know. But we are small, only 400,000 people. It's difficult to create the necessary infrastructure to run a modern healthcare system. So we are lagging behind in some of the infrastructure, whether it's medical equipment or facilities, and we need to address that. We need, actually, I believe we need a rather big effort. When it comes to the workload and the workforce, which has been alluded to, we need to find ways to manage, you know, the workload of today and the future with the staff that does not increase in line with the demand. So in Iceland we have, I must say, a primary care service that has not developed to the extent that we would have wished. On the other hand, we have a secondary care services from private practitioners, mostly physicians, that has grown through the years in some ways to meet the needs that is left because of the primary care. And I think we are almost at the stage where we need a reform. We have to find ways to make or maximize the use of the resources that we have, and mostly that is staff. So we need to strengthen the primary care, I believe, and we need to design the services based on the need, the current need and the future need of the population. I think in Iceland, like in many other countries through the years, the delivery of healthcare has developed or has been driven by the healthcare providers, rather than in some cases the needs of the population. And we need some investment in order to really make the most of the growing technology in healthcare, digital technology. We need some investment. So I rely on the minister to really come up with that. Thank you.
Thank you very much, Rudolfur. Rasmus, how can Lua and the Nordic collaboration help you both deliver and influence political decision making?
I think it can do that in many ways. One of the first things I realized when I went from being a clinician into the management board and the political area is that it's very different. I mean, we encourage our clinicians, our researchers, our staff to be very innovative and trial and error. That doesn't work when you are a minister. So when you are a minister, you need to be confident that the changes you make, they actually work. You don't have that many trials to take or errors to make. So I think that what I've already realized is that it makes the politicians around me much more confident that I actually can be very transparent about models in other countries which they think that we look very much alike. And they are much more confident when we are moving into changes together with Nordic countries, with the same kind of healthcare systems, or even that some of the Nordic countries have already done it. So I think and have realized that it brings confidence to the political arena and to the politicians around me. So that is one thing, what comes out of collaborations across borders. The other thing is that I think, because I heard in your question you said, what can others learn outside the Nordic countries. And I think that we need to learn that we are all small when it comes down to the pace that is needed for the transformation of healthcare system. So we need to collaborate, and we need to do that in much larger groups than we do today. And we also have to deal with something that is counterintuitive. I'm brought up in a setting where we always celebrate when we do something bigger, or add more, add a pill, add a diagnostic test, add a treatment, add something. Never when we reduce something. So it is a cultural change. And I think when we realize that, and we realize that we need to collaborate and accept that somebody is better than us, then we are on the right path. And I think that is a take-home message for all of you who aren't quite there yet, if anybody is there.
Thank you very much, Rasmus. Elina, you are representing Matti Bergendal, who is the CEO at the University Hospital in Helsinki. You are also serving as the new member of the steering committee. What have you heard so far?
Yeah, well, it's really interesting to hear from our Nordic colleagues, and we have very similar challenges, and also our goals in improving our healthcare systems are very alike. We have just undergone a major transformation of our whole national healthcare system in Finland about 3 years ago, where the responsibility of providing specialized care, primary care, social services, and also emergency services was moved from the municipalities to 21 well-being services counties and the city of Helsinki. And another very large change that happened at the same time was the way that healthcare is financed in Finland. So they all get a fixed budget from the government, and then they are autonomous in deciding how they spend that budget to provide the services that their population needs. And that has been a very big change. It's still ongoing. It hasn't been easy, and there have been considerable challenges, but it has woken people up to think about how can we make the money produce more health, and what can we do to make things wiser and not more. So we are on the way, but it's going to take time, I think, to get there. And we also need to embrace the change and look around us and see what our very close neighbors are doing and learn from each other to meet those goals. So our organization, HUS, is a large university hospital. Our turnaround is around 3.1 billion. We have 27,000 employees. And we will be the first public healthcare organization in Finland to balance our budget in this new system and also cover the losses from previous years. So it can be done, but it takes a lot of determination and a lot of situational awareness from the whole organization. And everybody needs to learn how the new system works and just think differently. So it's a big change that we're asking from all of the employees in the healthcare system. Yeah.
Thank you very much, Elina. Bobo, another CEO perspective on collaboration between the countries and also the political view.
No, I think from my perspective, I was at the Future of Health last week in the States, and the globe was represented. And I think what we can contribute with from the Nordics is also to lean in the global perspective. We need to understand how we can learn from different healthcare systems. I don't know if there is any representative here from Apollo, but Apollo have proved to be very productive in their ways of working, and what can we learn from them? I think the exchange and getting input. One problem from the Nordics could be that we might be also looking too much inwards, so we also need to have an outreach outwards. I think that is super important in the learning phase. from the political perspective and the financing to working within a healthcare system that is 100% tax funded. And we have the same model as in Finland, where we get a fixed budget, and then it's up to the CEO to actually figure out how to solve the operations. That means that you need to work with psychology safety. You need to empower your local teams in being innovative, and also you need to trust on these guys here that we can find out better ways together, because otherwise we will never be able to do the shift of the growing population. Or if you look into AI, all of the new things coming up, but we are not deploying more than 5% of that into actually doing value for our patients. So that is to be close to the politicians and the policymakers, and bringing up, for example, for us in the Nordics, is data transfer between countries, taxation system that looks alike, and legislation that helps us to move forward in transformation. I think that is something that I direct to the minister to continue with her colleagues to discuss, because we need help. And within Europe, we are lagging behind compared to other parts of the world where data travel more easily. But we need also to have a secure and safe travel of data into our, for example, AI learning systems and platforms. So a lot of really hard things to think about from a CEO perspective during these transformational times. I think that every leader thinks that their time is the most challenging one, those during the Second World War or those who are in different hard times. But on a global perspective, we are in a real transformation at this moment, and we need to come together and think closer, smarter together. Thank you.
Thank you, Bobo. And you say also, we just can't produce us out of the problems.
It's impossible.
That's impossible.
Yes.
We have to work smarter and collaborate more. We have now listened to some CEOs and politicians about the visions and what we want to achieve, and how we do it in small ways and some big ways, and we want even more. Katrin Bjerke, you are head of international relations at Oslo University Hospital, and also a key member of NUHA's steering committee. So how can you help us moving from vision to action?
Thank you, Anders. And what I like most about my title is the last word, relations, because it is all about relations. I think that going from vision to action, and I will try to explain this from a NUHA point of view. I think it's three perspectives that is very important. The first perspective is trust and professional autonomy. We need to trust each other, and we need to trust our professionals. We need leaders to show direction and to create energy, but we can't tell our professionals how to do it. So we have to trust in each other, and we have to have professionals that are doing the business on their own. So trust is not only a value, but it's a leadership principle. The second perspective is commitment and shared responsibility. I think that a lot of us are sitting in networks and groups, and we all share the same goals, but we have to all really commit in the work, and it comes to all the roles in the collaboration. So not just respond to emails and not just respond to things that happen, but actively take part in the change. And to make change, you have to involve people, so it's important. So that was the second perspective. And I think the third perspective, and we heard this morning about governance and how to make structures to make things happen. And we are very good at making huge governance models, also in hospitals and also in the Nordics. But something that is very important is to make very light-based governance models. So to define roles and responsibilities is important, but you really have to have a governance model that enables energy and power within the professionals who are helping us making the changes. So I think that was 3 perspectives, and I guess that the rest of the panel agrees or not. We will hear. Yeah.
Thank you very much, Katrin. You can all respond later. And now I want to listen to Alma again. What you have heard now and the other speakers, do you think we, with our collaboration, can help you to succeed?
Sure, it has been very interesting to listening to all of you. And I strongly agree with Rasmus about the qualities needed for change and transformation, humility and curiosity. But the strongest catalyst for change is urgency. We saw that during COVID, and urgency is certainly here already. And it was very good to hear you talking about how you mean to transform healthcare. I think our most important task is to help our employees, our politicians, and the public to understand the urgency so they can come and take part of this transformation that is needed. I agree with Runolfur's analysis of the Icelandic healthcare. We face infrastructure debt. We face it in buildings, in staff, in digital technology, in equipment, and the economic collapse in 2008 didn't help us. And as you saw in my presentation, we are using 8.3% of our GDP for healthcare, lowest in the Nordic countries. And our government understands that we need to, I'm not going to say spend, but invest more in health. But our primary goal now, we are a 10-month-old government, is to stabilize the economy in order to be able to afford healthcare and welfare. So our budget is a little bit frugal at the moment, but we certainly mean to do better. And I still think that strengthening primary care is the anchor, and Runolfur mentioned that. And we see that throughout the Nordic countries that strong primary health care saves money for specialized care. And we should embrace innovation, but stay human. We should reward collaboration, not silos. And we should treat workforce well-being as a core infrastructure. So I've been taking notes from all of you, and I was especially interested to hear Bobo talk about hospital at home. Not that concept, I know that, but rapid response team at home, because 20 years ago I introduced a rapid response team in our university hospitals. So I thought that was very, very interesting. And also to hear about how we are helping each other doing research and try to get more evidence for what we are doing. And we have really big opportunities there. The European Health Data Space is on its way, and that will make things more easy, I think.
Thank you very much, Alma. I don't think I will ask Runolfur this question. I go straight to Rasmus about investments or budgets, if you like. You have done some major changes also in the system of Denmark. And I know you talk about investments and the money, economy. Some of you are talking about we don't need more money, we need help to make the changes. And you have just had these examples from NOAA perspective of the platform trials. Do you need more money or do you need more help to do the changes?
Actually, I'm saying that it is not money we need. It is nice to invest in healthcare, but it's actually not the money we need, it's our staff. And we have a lot of resources, but some of them we're using wrongly. So what we need help to is actually politicians that help us changing some of the rules there, some of the legislation, some of the pathways that is very difficult when we want to do joint collaboration across borders. We can do it, and we have already done it, but it normally takes a year to get it all right. We want all these processes to be speeded up. So I think we are very lucky now that we are actually in a situation where we sit down at the university hospitals, talking to patients' organizations. They realize that this is needed. They don't want us to waste resources on patients, which probably or maybe harm them. They are actually alongside with us doing these changes. And our politicians get very confident about that. And we are not coming asking for money. We are coming asking, help us doing this easily. Help us work across regions within the country, between hospitals and across borders. So I actually think we are in a very good place. And it also helps that I'm not representing Denmark, but I have colleagues from all the Nordic countries saying the same. So it's not just an invention coming from inside the country. It is actually also sound voices from neighboring countries, and that means a lot.
Thank you. What about Sweden, Bobo?
Sorry?
What about Sweden?
In Sweden, so the SUHA, the Swedish University Hospital Alliances, and how we work, I think if we talk about investments, money is part of the fuel that can drive change. We have also on the graph, we are on the far right side that Alma was showing, the expenditure of GDP. And if we look to the outcomes from the OECD report, we are in a very good position for healthcare outcomes. What I see is needed is shifting of investments. Today I spend 70% of my budget into to workforce. What we foresee when we're doing our models is that we need to reduce that to 50% to be able to afford new diagnostic, new treatments, and that is a change in culture. So how to shift the expenditures will be important. We also need to understand how to make way for the virtual care and the innovative system. One of the problems we have in the Nordic is that the university hospital innovation systems is not able to build capital. So none of us is able to actually keep the capital within our own facilities or in our own system. And it goes out to startup companies, then leaving the countries and the region and going to other parts of the world, which then will benefit. So that is something we need to come around to have a sustainable way in working in the future. So I agree with Rasmus. Well, at the moment we have enough money. For the future we need to build also capital. And that is a little bit different because in Norway you have the oil. And so we need to trust for the system also to build sustainability in the future for the society, of course, and that goes for all of in the audience, all of us thinking of how are we going to build sustainable systems for our inhabitants, for those that we actually are there for to serve. And that is a huge task for the future. We can solve it, but we also need to address sustainability at the same time. I think that is part of the key also learnings from this morning in the sustainability sessions. We need to put much more focus on sustainability as a system.
Totally agree. And sometimes the oil actually is a problem for being innovative. We experience rough times all around the globe. So now, Elina, Runolfur, Catherine, what advice would you give to other hospital leaders who is not from the Nordic countries on what to do? Elina?
I think that the most important thing is that we must not be paralyzed in front of the constant changes and challenges that we're faced with. Instead, we need to embrace that opportunity to make changes and be proactive instead of being reactive. I think that is very important so that we can reshape the healthcare models to be able to answer to the challenges of the future as well, so that we have something that is sustainable and can provide health and well-being to all citizens also for the future years.
Runolfur?
Yeah, I agree with Elena. Every challenge is associated with opportunities. And look for those opportunities. Don't be afraid to enter major transformations if they are needed. And I believe in most countries, we need to change the ways we deliver healthcare. The challenges are mounting, and we have to respond. Using a data-driven approach, creating a good strategy, and involving the workforce, because we are all in this together. I think this is really what needs to be done. In terms of the expenditures, which are really important as well, find ways to control those, get rid of low-value care. It's present everywhere. And in terms of allocation and use of funds, be transparent, monitor what you're doing. I think these are sort of the critical issues. Thank you.
Thank you. What about you, Catherine?
Invest in leadership. I think that's one of the most important things that healthcare leaders do. So invest in leadership in your hospitals. And don't tell people what to do. Ask them how they want to do it.
As easy as that. Thank you very much. Now, we're going to round up this session. We've heard about the productivity. We have heard about the low-value care. To stop doing what we know doesn't work. And think about being best to be number 2. Think about it. We want to be the best, but we should be best for being number 2. Because so many of us are doing so many great things that we can learn from. And this is our collaboration an example of, absolutely. We are 30 million people altogether. And that's not that many, but also quite substantial in Europe. So Alma, you can have the final words. The hope for the future, we vote for you, or the people of Iceland do. What's our hope and your hope for the future to reach our goals, and what we really need to do for the future?
As I said before, we need to change, and we must all be a part of it. The public, the employees, the directors, and so forth. So I think it's crucial that the public understand the urgency and gravity of the situation and take better care of their own health, and also that we help them with that. And in one of my slides said we go back to basics. It's about health promotion, it's about sleeping well, eating well, about physical exercise, avoiding tobacco and alcohol and so forth. And that's crucial, but also to embrace new knowledge when it comes to public health, like using data, behavioral sciences, and so on. So I really think we must do better at when it comes to public health, both prevention and health promotion. And I think that is the one most important thing for us. And number two, as I said, is to use our money that we have for healthcare more wisely. And that needs all of what we have been talking about. We need to transform and completely change both how we organize healthcare and how we deliver healthcare. So we need both to use technical solutions like digital transformation, AI and so forth, but also to innovate when it comes to processes. I think these two things are the most important way to go forward.
Thank you very much. And thank you very much to all of you. It's been very nice sharing this session. Even though we deliver great health services today, we all know that isn't good enough tomorrow. So we really need to improve. Thank to the audience. So great that you all come. Have a great evening. Thank you very much.